I'll be presenting on Miltefosine related keratitis, clinical characteristics and management. I have no financial interest in the subject matter. Miltefosine is a drug that is originally developed as anti-malignant drug. It has been recommended by WHO to treat all types of leishmaniasis since 2002. And since that time, it is the first and still the only oral drug that can be used to treat Kala-Azar and its sequelae, that is dermal leishmaniasis. Kala-Azar, as we all know, it's caused by Leishmania donovani, and in 10 to 20% cases of apparent successfully cured cases, they develop post-Kala-Azar dermal leishmaniasis. And that is a potential source of Leishmania infection, and it is characterized by skin rashes. The prevalence of this PKDL in Bihar is 4.4 to 7.8 per 10,000 population. So the recommended doses of Miltefosine for PKDL is 100 milligrams per day for 3 months, that is 84 days, with some uncommon adverse reaction like mild gastrointestinal symptoms. However, there are recent reports highlighting some serious corneal complications in patients receiving Miltefosine. The lacuna of literature is that all the cases were documented with a clinical impression about the finding of Miltefosine keratitis. They have shown the varied presentation from Murren's ulcer to scleritis, and little is known about its clinical course and its management. So in this paper, we discuss the diagnostic clinical features, progression and management of Miltefosine related keratitis in our 6 patients. This study was conducted retrospectively from 2018 to December 2021, including 6 PKDL patients receiving Miltefosine, and the study was approved IEC and written informed consent was obtained. The evaluation included complete medical history focusing on the drug used to treat Kala-Azar and PKDL, documentation of dose and duration of treatment and the onset of treatment after initiation. We also performed the casualty assessment of adverse drug reaction to Miltefosine by WHO UMC criteria. We worked up all cases of keratitis, including their size, location, pattern, depth, and presence and absence of epithelial defect, hypopyon, corneal sensation, and edema. And laboratory evaluation included the smear examination and culture and PCR to detect the presence of LD bodies. RK39, which is a serodiagnostic test performed in all cases, and a skin biopsy to confirm the PKDL again. So results of our 6 patients. First case was of bilateral keratitis. He was receiving Miltefosine for 48 days, and he continued taking this drug for another 17 days after appearance of ocular complaints. On the day of presentation, the patient had ring paralimbal full thickness infiltrate with presence of hypopyon. And since this was our first case, we didn't start steroid on the day 1, and we waited for the microbiological results. Until then, we started the high fortified antibiotics, and within 2 days, the ulcer progressed and involved the central cornea, resulting in corneal thinning, and for which patient was operated for penetrating keratoplasty. And after the result came negative, we started the oral and topical steroid, and left eye responded very well and resulted in 6/12 vision. Another case was also of bilateral keratitis, and this patient was receiving Miltefosine for 35 days, and he continued taking for another 20 days this medication after ocular complaints. And this was a very classical picture. Patient presented with the ring paralimbar infiltrate rapidly extending to the central as well as the circumferential part, and for which he was operated for PK. And left eye responded with the topical and oral steroid, and giving a avascular scar within a period of 4.5 months. The rest 4 cases of 6 cases, they were unilateral keratitis, and they had a history of Miltefosine intake from 38 days to 65 days. And one thing was common in all, that they stopped Miltefosine by their own just after feeling the ocular problems. So they responded very well to topical steroid and attained good vision in a course of 3 months. So in results, the ocular symptoms were common: pain, watering, photophobia, diminution of vision, and there was a common pattern of keratitis in all the patients, like ring-shaped full thickness paralimbal infiltrate with the edema and hypopyon. 2 cases who continued taking the drugs even after appearance of ocular symptom, they had bilateral keratitis, and 4 patients had unilateral keratitis. The laboratory test, smear culture, PCR were negative for microorganisms, while RK39 and skin biopsy were positive. Management, discontinuation of miltefosine and initiation of corticosteroid therapy were the mainstay, and casualty assessment by WHO UMC criteria showed probable association between this keratitis and the miltefosine in all the patients. So we found a consistent pattern of keratitis and clinical course in all the patients who were receiving miltefosine, and on the basis of our result, we could divide miltefosine related keratitis into two stages. Early stage where the ring peripheral infiltrates were present with the intervening clear zone between limbus and the lesion. And in advanced stage, the infiltrates extend both centripetally and circumferentially to involve the center and the limbus, and the ring lesion evolved into a ulcerative keratitis. So its mechanism of keratitis in patient receiving miltefosine is not very clear, but drug might be directly toxic to ocular tissue. And this development of keratitis may be of an autoimmune response. So management of this case can be suggested by stopping the miltefosine, excluding the infectious etiology, initiating the corticosteroid as early as possible, and differing PK for complicated cases. So this study indicates that prolonged use of miltefosine might cause keratitis that resembles infectious keratitis. Early diagnosis with discontinuation of the drug and initiation of corticosteroid are key to successful management. And this study also emphasized the need to strengthen the pharmacovigilance program in endemic areas that monitors this serious complications. And patient receiving miltefosine should undergo periodic ocular examination by an ophthalmologist. These are my references. Thank you.
You have noticed apart from keratitis?
No, in these patients only infiltrates with the intense conjunctival congestion, and all the symptoms like pain, watering, photophobia were there. Apart from these, I didn't find any significant finding.
What was the average the duration of miltefosine and the presentation?
In my series, it was 48 days.
48 days.
48 days.
So it takes quite a bit of drug to cause this.
Yes, every day they were taking 100 milligrams.
Okay.
And
so did you calculate any accumulated dose of the drug which can lead to, like we calculate for hydroxychloroquine, right?
Yes.
That cumulative dose, I will say rather.
We wanted to
So,
do that,
yeah.
but the facilities were not there.
No. The just a mathematical calculation, like if patient is taking 100 milligram daily.
Okay, cumulative dose.
Cumulative
for 48
dose,
days,
yeah.
so you can say that.
Yeah. So was it correlating for all the patients, the cumulative dose, or the dose was given same to all the patients?
Yeah, same to all
Same
patients,
to all the
because
patients.
everyone was
Yes.
more than 25 kgs. And if there is a recommended dose, 100 milligrams per day, if the patient weight more
Okay.
than 25 kgs. And if the patient is less than 25 kg, then the doses will be half.
And what was the histopathological finding in buttons you excised?
Yes, we did histopathology in 2 patients where we did PK. And except for intense inflammatory reactions.
Was it neutrophilic infiltration or lymphocytic infiltration? I mean, the neutrophilic, right?
They were neutrophilic, but not exactly these type of finding. Like we were looking for some leishmania, some LD bodies, like thing, but we didn't find any conclusive finding.
Okay.
So did it begin like a stromal, sterile stromal melt which got secondarily infected? What was your?
Yeah, actually, we wanted to rule out that only before starting the steroid. So we did microbiological examination in all the patients, and we didn't find any infective microorganism in all the patients.
So you recommend screening what? After starting the drug, 3 weeks after starting the drug, you recommend screening
I
them,
would
or?
recommend because every patient, like I showed you that unilateral keratitis, they stopped the drug immediately. So, and they recovered very well, and they didn't require
Right.
even PK.
But what is the
or-
duration? 3 weeks, 2
So
weeks,
I would suggest
4
that
weeks?
1 month.
1
because
month,
average
4
is-
weeks, yeah.
Average was 48 days. So I would
Right.
suggest after a month, if miltefosine is continued,
Right.
then better to screen, get a good screening by an ophthalmologist. And it needs a good pharmacovigilance also.
Any other question?
Thank you.
Thank you.
Thank you so
so much.